Today I'll discuss what going lateral is, or using lateral movements, particularly in the spine versus the extremity joints, when using repeated movement testing. Now, as an overall synopsis, repeated movement testing is a very living and breathing orthopedic test. I use those words because it is so dramatically different than other orthopedic tests that we use, namely imaging testing and orthopedic special tests, also known as OSTs. It's living and breathing because it is a test that really challenges physiology or functions of the body, and therefore it requires a lot more than just checking to see if a ligament has lost integrity or looking at an image to see if a bone has lost its integrity. So repeated movement testing was developed by Robin McKenzie. So some people call this the McKenzie method or mechanical diagnosis and therapy, MDT, because repeated movement testing is designed to see if a patient's complaint is mechanical in nature, which mechanical has kind of different definitions if you ask different people. But for me, and I think for a lot of people, clinicians, it means a complaint or a disorder that is affected by movements and positions and remedied with movements and positions. And I should have said the word specific because we are talking very specific here. For example, the joint complaints that are local, referred, or radicular are worsened with joint flexion in terms of movements and positions or postures, and improved or completely resolved with movements of extensions, for example. Extension in repeated movements or extension in sustained or everyday movements. So in repeated movement testing, there are lots of different movements we can test, and we can break the body into three planes, of course: the sagittal plane, the frontal plane, and the horizontal or transverse plane. So going lateral means using something outside of the sagittal plane, using something on the side laterally. In the spine, we will do repeated movement testing in a lateral form in several instances. The first kind of most obvious instance is when there is a relevant, obvious lateral deformity of the spine. The two most significant ones here are side bending of the neck, so the patient's neck is stuck in lateral flexion or side bending, and a lumbar shift of the lumbar spine, where the lumbar spine is shifted in a side glide on the pelvis, laterally to the left or laterally to the right. Now, there are criteria that you can look at in the definitions. Robin McKenzie and Stephen May wrote 5 textbooks on this. There's also many lay books, such as Treat Your Own Back and Treat Your Own Neck. But in those situations, when the deformity is obvious and indicated that it's seen by the clinician as relevant to the patient's current complaints, then we will use a lateral procedure. We will go lateral immediately, because the thought process is the fact that the person is stuck laterally, the spine is shifted to one side, is the preeminent problem, and getting that spine straight is therefore the first order of business. That's not to say that the patient might not need a sagittal movement secondly, but the first movement is going to be the one that gets the person straight. So in the case of a lateral deformity of the neck, we would be doing side bending in the opposite direction, and likewise in the lumbar spine, if the patient is shifted with the shoulders to the left, we are going to be trying to shift the shoulders, aka the spine, to the right first as the number one issue, the number one thing we need to attack. And those things can vary in terms of how much effort they take, but there are people for whom it is very difficult to get straight and can take a lot of effort and time. So going lateral in that case is kind of the more obvious example. But if we think about the spine, there are 3 main indications we would use a lateral movement in the frontal or transverse plane if these 3 things happen. 1, there's no effect with sagittal movements with repeated movement testing. 2, sagittal movements improve a patient's complaints, so the disorder is improving, but it plateaus in improvement. Or thirdly, sagittal movements can worsen the patient's presentation. That means that globally, overall signs and symptoms are worse off, and so we can look at another movement. Of course, the first line in helping a patient is diagnosis. So we are using repeated movement testing as clinicians, and I kind of think of testing in those three buckets. Imaging testing, quick orthopedic special tests, which can take seconds to minutes, usually seconds, and then thirdly, repeated movement testing, which can take hours to days to weeks. We're going to be using repeated movement testing as clinicians if the specific verbal history and the physical exam make me think as a clinician, this is the most important test for this particular patient. If a patient comes and has a black and blue wrist, just fell on it, felt a pop, which I have seen, the best test for that patient in this hypothetical example is an X-ray. For other patients, they twisted their knee going for a layup, they heard a pop, it feels like what they think is an ACL, you do the ACL test, it's positive. For that patient, the number one indicated test was a Lockman or a pivot shift test or another test for ACL integrity, either in the clinic or via imaging. So repeated movement testing is something I will use if I want to figure out, is this disorder a mechanical issue that can be resolved by moving repeatedly into the 1 or 2, and in some circumstances 3, specific movements that joint needs to get back on track. So we use lateral movements in the spine, however, not as often as being successful with sagittal plane maneuvers, particularly retraction, extension in the neck, and extension in the spine. The hypothesis, which I think is quite solid, is that movements that we don't go into on a day-to-day basis, or hardly ever, for example, are often the remedy. There are not many necks that are in protrusion all day, staring at cell phones and books and laptops, that need protrusion to get better if they are a mechanical disorder as the diagnosis. Same with lumbar spines. If you are seated for 6 hours in lumbar flexion and you never lie on your stomach, you never, of course, stand at a countertop and bend backwards into full lumbar extension, you probably do not need more lumbar flexion to get better. However, although this kind of makes intuitive sense, it is not really agreed upon in the orthopedic community, because you will see so many patients with lumbar complaints, for example, doing pelvic tilts, knees to chest, toe touching, hamstring stretching, piriformis stretching that flexes the low back. You will see them doing a flexion-based approach. So repeated movement testing, if we decide to use it, it's answering the question, is this disorder mechanical or not? And so therefore, as a clinician, whenever you decide to use a test, it's because those first two parts of the evaluation have given you enough evidence that this is the indicated test. I find it's indicated in at least 75% of patients, if not more, which is in stark contrast to most clinicians who, the average clinician is never using repeated movement testing. And going back to why I say it's living and breathing, it's like a functional test, kind of like hopping on a treadmill and doing a stress test for your heart. We are challenging your cardiac system and seeing how it responds. With repeated movement testing, we are challenging the musculoskeletal system and seeing how it responds. It is very different than, like I said, seeing if the integrity of a ligament is gone, or pushing down on the shoulder joint, the arm, and saying this is therefore weak and painful, so it's a supraspinatus problem. Again, if you go back to Cook and Hegedus, they wrote a wonderful textbook several years ago that actually looks at the evidence for that second bucket of testing, orthopedic special tests, and they come to a conclusion that most orthopedic special tests do not have very strong evidence to support them. I highly recommend that book. I think every single clinician should read that book. It's laid out in kind of a test by test, like each page has a test, and it goes through what was that test based on, or the test bias, what's the sensitivity, what's the likelihood ratio, what's the specificity. It's a wonderful textbook. In the lumbar spine chapter, just to highlight one chapter, there are at least 30 tests examined, orthopedic tests, I think 31 or 32. Only 2 get a score of strong evidence. The prone isometric lumbar test, which I believe is just testing to see if the complaints seem musculoskeletal in nature. So that's not a test I'm really putting much strength behind myself. The second test that gets a score of strong support is testing for centralization using repeated movement testing. So repeated movement testing is one of two tests that gets the highest score in terms of evidence, yet very few clinicians learn it and use it. I hope, of course, that will change. But repeated movement testing, like that stress test, we are going to put a movement through your system, like 30 retraction extensions of the neck. Then we will retest all the signs that we collected in the physical exam and all the symptoms that were named in the verbal history, and use a cause and effect analysis to see if the effect is worse, better, or about the same. And the clinician has learned an algorithm about how to use repeated movement testing to know what to do and how to interpret the results of that test. Going lateral in the spine, mostly I can use this for cervical, thoracic, or lumbar. One example or analogy I use for patients is kind of like nailing a nail into the wall. If we're doing that in the sagittal plane, let's say neck extension or neck retraction extension, but it's plateauing or it gets worse or there's no effect, it could be because the nail is actually off to the side, or extension moved the nail off to the side because it's so one-to-one that this movement does make the patient worse. So therefore we need to hit it from the side. We need to hit that nail laterally, if you will, until we have signs that show us it's ready to hit that nail again straight. For many patients, that could be the symptoms have come out of the periphery and centralized in the middle of the spine. For other patients, is their lateral deformity or their lateral kind of loss of range of motion has abolished. So that nail analogy makes kind of sense when you think about the intervertebral joints and the joints of the spine as being circular. We can go to the side, hit it from the side for a bit, and go back to the middle. Sometimes that's very quick, meaning you only need a few taps of the nail on the side on the right, or sometimes you need to really hit it hard on the right for a week. Patients will be variable, but again, clinicians need to learn how to interpret this test because it's so much more nuanced than let me just push down on your knee and see if you have a chondral defect or patellofemoral pain syndrome. When you use this test, it sounds like it's going to take a lot longer in terms of care, but what I find is that it really reduces the amount of care because the diagnostic process may take a bit longer, but then the diagnosis is going to be more likely to be true. So repeated movement testing may take 3 or 4 visits or 5 visits to find that right movement, including sagittal movements or lateral movements. But once you find it, you just use that movement to fix it and therapy is concluded. Obviously, for a lot of people, we're finding that movement on visit 1, for someone on visit 2, and therefore we're not seeing them more than 2 or 3 visits. But for some people, it's a little bit more challenging to find that specific movement. For example, lumbar extension, is it standing? Is it standing with overpressure? Is it prone? Is it prone with overpressure? Is it mobilizations? Is it prone sustained? Is it manipulation? There are different variations on a theme. Extension is not just extension. You have to find the right load, dosage, frequency, amount of force, time. You need to make sure that the patient is not undoing it with movements and positions in the opposite direction, for example. But going back to today's discussion, we do go lateral quite often, less so in the cervical spine versus in the lumbar spine. It's not the majority of patients by a long shot. In the thoracic spine, I don't know the specific numbers when we ask clinicians who use repeated movement testing, but I believe thoracic extension is still going to be the predominant repeated movement that is successful in the majority of patients with thoracic mechanical disorders. But we do need to go lateral. We need to know when to use those movements. We need to kind of educate people. If there are other analogies I've learned. Gary Dykes was telling me that sometimes he explains it like there's a curve in the road, we just don't know how deep that curve is, meaning we might need to go left for a day or we might need to do a left maneuver for longer. That's another way of phrasing it for patients if it helps them understand what we're doing. Of course, in the lumbar spine, this ties into the disc model. Which way are we kind of applying force or pressure to the disc? In the extremities without discs, that doesn't apply. The disc model, I think, is the model of best fit to describe what is mechanically happening when you apply a very specific force to a joint in the spine. In the extremity, unlike in the spine, we can simply go to a lateral procedure first without needing to kind of test sagittal as the first line of defense. For example, for a lot of shoulder mechanical problems, or what we want to diagnose as possibly a shoulder mechanical problem, I will look at internal rotation up the back first. For hips, I may also look at internal rotation first. For hinge joints like the elbow and knee, I would say it's uncommon for me to go outside the sagittal plane, or ankles, for example, or wrists, but it's not the same kind of expectation as with the spine. And I haven't seen a deformity in an extremity, but they could exist, especially with trauma. So if you have questions about what going lateral or using a lateral procedure looks like, feel free to leave a comment or a question. I'll do my best to answer. And if you're a patient that's really struggling, treat your own back or neck, maybe Fruitful. It helps you kind of self-assess if your problem is mechanical. Big picture, I find that about 75% of orthopedic disorders are mechanical, but because clinicians don't even have that concept or that idea, because it's not generally taught in schools, if you don't have the idea that that diagnosis exists, you're not going to diagnose it, of course. So without that paradigm, people are being told that their muscles are tight, their fascia is tight, that they are weak, that they have structural problems that are relevant to their complaint, when they might just have structural problems that are apparent on very sophisticated, imaging from the last couple decades that shows issues, but that are irrelevant. We obviously, or not obviously, but we have lots and lots of studies that show people with zero complaints with structurally compromised joints. For example, I did a post where I delineated 10 studies that looked at the shoulder, asymptomatic shoulders with a plethora of defects in terms of tears and tendinosis in the labrum, in the rotator cuff, etc. So if you don't understand that a lot of problems are mechanical, and I'm asserting that 75% are, then you will likely blame muscles or structures. Structures such as labrums, such as menisci, such as structurally compromised disc. When the disc is not structurally compromised, it just needs a specific mechanical force to rectify the problem. So patients can use those books to kind of go through and self-assess to see if their problem is mechanical or not, which will be very different as a self-assessment process if they've been to clinicians that have not used those tests, but have instead focused on imaging tests and quick orthopedic special tests. But like I said, leave a comment or leave a question. If you think I can give an answer, I'll do my best.